All right. Good afternoon and morning for my West Coast folks joining us today. My name is Dr. Vikash Modi. I am pleased to bring you another Prenuvo provider webinar. Our topic this month is on degenerative joint disease and spine diseases, which is something that we absolutely see on whole body MRI and can really kind of dive deep into. So just a quick reminder, I'm the Senior Medical Director for Preventative Medicine here at Prenuvo, so a primary care trained physician. But I'm today joined by a good friend and colleague, Dr. Todd Berry. He's one of our lead diagnostic radiologists and helps lead the musculoskeletal imaging program at Prenuvo, which, yes, we do have sort of people who are really strong in different areas scattered across the organization. And Dr. Berry's particular strength is in musculoskeletal. He's excellent in all the other fields too, man. So Dr. Berry is very, very gracious to join us today. He's going to be driving most of the conversation. I'm just the warm-up guy. I'm the opening act. So just to pitch to the group today what we're going to be talking about. Again, this is understanding the role of whole body MRI in evaluating spine and musculoskeletal systems. We do not sort of propose to be the exclusive type of imaging modality for diseases of those conditions, but we are an excellent screening test for anybody who has maybe not got symptoms or has early symptoms and wants to start to understand more about those conditions. So detecting, things that you didn't even know about is absolutely our forte. And then certainly things that have been already known about and we're sort of monitoring are things that we're going to talk about today as well. The other thing to think about is the real life case examples that we're going to be showing today, that we've got a really nice spread of different conditions that we can really make a nice case for through Prenuvo scans. But that also opens up the opportunity for us to talk about where some of our limitations live. Just a quick plug for our clinics. We are now at 22 locations in the U.S. We just opened the dedicated clinic in Coral Gables, Miami. We've recently launched Philadelphia and St. Petersburg, Florida this year. So we're up to 22. And as our footprint continues to grow, our dedication to delivering a best-in-class service still continues to exist with beautiful spaces, concierge-level services, and of course, the most advanced application of MRI for the whole body screening. In fact, I'm happy to report that our consultation program, by the way, continues to expand, and now we're supporting enhanced scan testing such as neuroquants, body composition. So, to us, the ultimate key for our success is in fostering this trust and service quality and ultimately disease-modifying results that give your patients and give you, the referring providers, kind of confidence in what we're doing here. Just a quick review of what our scan is doing. We've got 50 to 60 minutes of scan time, incredibly efficient there. We also have newer add-ons that we've made available, which include neuroquantification I mentioned, body composition that I mentioned, and those are not really adding a significant amount of time to our table read time. And there's still no radiation or contrast material being used. We have this quality end-to-end control over everything that we do, that every Prenuvo scan is owned by Prenuvo clinics, managed by Prenuvo consultants and physicians. So we're able to kind of keep the time tight here, often less than a week for a whole body MRI, even less than 2 weeks for some of the MRIs with the add-ons. And last but not least, our reporting remains incredibly effective with results that are manageable for the patient, easy to understand, but also efficient for the provider to interpret and monitor those over time. So those are just a couple of the key things that we're still doing here that we're improving on. The last thing I want to talk about here before I hand it over to Dr. Berry is, again, just our machines and our experience. The 1.5 Tesla Philips and Siemens magnets are hospital-grade quality, latest hardware, constantly updated software, which accelerates the table to interpretation time, and still allows our patients to be comfortable as well while getting their test completed. They're able to watch or listen to their preferred programming. We give them really comfortable mattresses and coils and blankets that kind of really keep the body comfortable throughout this whole experience. And of course, ear protection, sound protection. And that's allowed us to achieve this 1% claustrophobia rate versus the national average of 10% for MRIs. So that's, I think, a really powerful thing that we've been able to achieve here. But now that I've reviewed the sort of ingredients of how we do what we do, let me introduce one of the chefs. So that's Dr. Todd Berry. Dr. Berry, again, being one of our lead radiologists here, specific expertise in musculoskeletal orthopedic imaging. He's put together a really comprehensive stack of cases pulled directly from Prenuvo archives. And he's going to be walking us through these to better understand the value of how a whole body MRI can inform us about musculoskeletal health, often before symptoms become debilitating, and gives us as providers a unique opportunity to intercept these types of problems earlier than traditional healthcare will allow us to. So without further ado, Dr. Berry.
All right. Thank you, Dr. Modi, for that introduction. As you said, I'm Dr. Todd Berry. I am a diagnostic radiologist here with Prenuvo, and my background is in musculoskeletal imaging and intervention. And I'm very excited to be here today to share, kind of what my background can bring to this whole concept. Something that I'm very passionate about, and as we all know, spine and musculoskeletal health are some of the most common complaints and reasons for office visits in the United States. So any sort of modality that we can do to kind of get ahead of things, I think is just really great. So, being able to bring my background to a company like Prenuvo that's looking at the whole body and then applying that to the musculoskeletal system is just very, very, amazing. So I'm going to take you through, kind of what we can see and what we can't see on our exams, and kind of help give a better understanding of exactly what you're going to get when a patient comes and gets a scan with us. So when it comes to the musculoskeletal system and spine, we're going to be able to look at the whole spine, look at the alignment, get an idea of the marrow signal, any sort of degenerative disc disease, facets, looking at the canal, looking at the neural foramina, looking at anything that's narrowed, or any sort of cord signal abnormality that may or may not be there that the patients may or may not know about. And then obviously we're going to be able to look at all the major joints, so the shoulders, the hips, the knees, and the ankles, unless if they're too tall. We're not really going to get a look at the elbow joints, or like the wrist and some of the small joints. We're not really going to be assessing that in any great detail. Obviously, we get to see the pelvis, so we'll be looking at the SI joints and getting a sense of the patients had any old fractures, any subacute or acute fractures, which we do see from time to time. And then one of I think the biggest, kind of things that we get to add and include with this are looking at the soft tissue abnormalities that may potentially be excluded from a joint on a dedicated exam. We're going to get a broad overview of everything. So with that, I thought it'd be helpful to show kind of an example of what the scans look like when we are reviewing it. So I'm going to pull up a scan here. So this is everything is anonymous. We put sort of a fake name, fake date of birth on all of our patients when we're reviewing them. But I wanted to just kind of show you, and obviously we do a ton of sequences looking at everything in the body, but these are kind of, sort of the 4 or 5 main sequences that we are looking at when we're assessing the musculoskeletal system and spine in particular. So, for here, you can see on this individual, first of all, we can number everything going from the top of C2 all the way down, which is also very helpful when it comes to like transitional anatomy or ambiguous anatomy. If you're just looking at the lumbar spine, calling one thing L5 versus S1, if it's ambiguous, it can be a little confusing. Here, we are able to count directly, straight down and get a really good sense of exactly what the numbering system should be. And this is the patient. Again, they've got very tight stenosis here. So, about 4 millimeters AP at this level at C4, C5, pretty high grade at C3, C4. And even here, we can start to see, suggestion of a little bit of cord signal abnormality that's right there in the cord. Now, again, we're doing the full body. You can see, we're scanning from head to toe on these larger coronal fields. So you're giving up some resolution with that. So there's a trade-off, we're seeing more, but you don't get quite the same detail as you would as if this was a dedicated spine. I can zoom in, and traditionally on a regular, cervical spine, for example, the soft tissues of the neck are going to be kind of blocked out here to give a little bit higher resolution here, of the cord, but we can still zoom in. And as you can see, just, cross-referencing, at this level, we can see that the facets are hypertrophied. We've got some uncovertebral hypertrophy. You can tell that this cord is getting deformed right here. And again, there's at least suggestion on, 1 or maybe 2 images that there's some cord signal abnormalities. So, as we know, even on diagnostic, like dedicated imaging of the spine, the symptoms don't always match up completely with, what the imaging looks like. So I don't know if this patient's symptomatic or not, but this is a good example of somebody that even if he's not having any specific neck pain or kind of myelopathy, that this would probably be a good example of a patient to go ahead and refer to a spine surgeon, at least to get them plugged in, get an initial evaluation, and maybe get a good neurological test to see if they're showing any early signs, and to go ahead and start getting them, appropriate therapy sooner than later before it becomes, worse cord signal, or progressive stenosis.
Yeah, we see this so often in our clinics and in our consultations. And I'll very often ask patients, okay, so now that I've shown you the pictures and explained what this is, what are your symptoms like? And we get a huge range of different answers, right? We get people who are, oh, absolutely, it hurts all the time and I feel this pain and radiculopathy symptoms. But we'll also get people who say, I don't know anything about this. This doesn't bother me whatsoever. So it's really that consultation piece that we find so useful, because then that helps us guide those next steps. That somebody who's not having any symptoms, I'm going to say, great, then that means we can kind of focus on the preventative measures. Let's talk about ergonomics and posture, strength training and flexibility, Pilates and yoga, and then maybe having some early physical therapy consultation just so they're familiar with those. So doing like preventative physical therapy is actually kind of like a mind-blowing concept for a lot of clinicians, but it's something that we absolutely recommend coming out of these scans. The other thing that we'll do, though, on the flip side, is just what Dr. Berry mentioned, which is like, yes, this is absolutely symptomatic. This is something that you should go see a spine specialist about and start working on your treatment plan, ranging from orals and anti-inflammatories all the way to injections and possible procedures. So lots of really different conversations that come out of seeing these pictures, getting these reports back, is then kind of putting it all back together with the patient's symptoms.
Yeah, and I think that's a great point. Just having the visual cues and the objective data of, for patients and for, the referring providers to see, this snapshot of what's going on at this time, I think can be very motivating for the patients to begin to want to actually implement the programs that you might be recommending. And again, so we're able to see alignment. This person obviously has a degree of scoliosis, since we're not seeing the whole spine on one slice. And I can confirm that just by scrolling through on the coronals. You can see, some curvature to the right in the thoracic spine, and then kind of down to the left in the lumbar spine, and just go through the whole, thoracic spine, which there typically isn't a whole lot going on there. And then, again, this person's got pretty straightened lumbar lordosis, and you can see they've got advanced disc disease at L4, L5, which is fused. And there's some bony hypertrophy here and causing, a more mild degree of foraminal narrowing at several levels, over here. And then just to give kind of an overview, this is the sort of field of view that we're looking at when we're reviewing a shoulder, and hips, for example. So you're not getting the dedicated kind of, small field of view that you get on a single, dedicated exam, but you are able to compare side to side, and you can tell that there is a degree of, degenerative change here in the clavicular joints. We can look at this on the axial images too, down here to the left, and kind of scroll through and see, is there any joint effusions? Is there any obvious tendon pathology? And on this patient, you can actually begin to see there's a little bit of fluid around the joint on the right. And then on the stir, you can see there is, some fluid. And I can be pretty confident that this patient most likely has, at least a high-grade partial tear, of this cuff. And you can compare that to the other side, and which looks more normal. Again, you're not going to get the same detail, but this is, again, if they're not symptomatic already, get them, referred to ortho, let them get a good exam, and begin that early therapy before they become symptomatic. So let's go back to the presentation here.
And as you're doing that, I think it's really important to highlight the language that you just used, which is that this patient more than likely has a high-grade injury to the rotator cuff. That, correct me if I'm wrong, Todd, so a whole body MRI, maybe true or false, a whole body MRI can be used for diagnostic imaging to help monitor a rotator cuff.
Yeah, I mean, again, you're not going to see subtle changes, but some of the bigger picture things is like, is there progressive atrophy? Are you beginning to get edema in the muscles? We're definitely going to be able to see that. So, it certainly has some utility, and, you are able to kind of compare that from side to side. So I think that is definitely something that could be useful.
And so
this next slide just kind of shows.
Is that we just to say that's what we see in the reports is language like that, like this may indicate. And so our recommendations are pretty clear. I think that we say, hey, you would benefit from diagnostic imaging, dedicated imaging to confirm the suspicion or this diagnosis. So we both defer the patient to get that diagnostic or dedicated imaging done, but we also want people to understand that this is not really a modality for monitoring known disease or known injury. It's really just like you've got some symptoms there and you want to sort of know if there's a high risk of injury or low risk of injury. That's where our scan will become useful. Very often we're catching things in an asymptomatic or pre-symptomatic phase, but if somebody knows they have pain in the rotator cuff and they're really concerned that something's been injured permanently, it's really important that we will comment on it, but there's the next follow-up step needs to be taken.
Exactly. Yeah. So that's a very key point to keep in mind. So this is not replacing a diagnostic, dedicated shoulder, but it can certainly be useful to help guide what needs to be done if we're seeing signs, and then obviously if the patient is showing signs too. And, we do try to keep everything, our language, very patient friendly, with the reports, being patient facing and, kind of an easy to understand language for what they should be doing next. And kind of just showing, this is an example of just level by level what a report might look like, commenting on the things that we can see typically, and then kind of explaining that in a more patient friendly, language, so that they have a better understanding of who they should see next or what they should do next. And again, just another kind of example here of, looking at the spine, C-spine, obviously C5, C6 is very common to have, pretty high grade stenosis. This is not quite as severe as the other case that I showed, but again, just, showing, getting a good overview of the spine, looking at the marrow signal on here. And again, with those larger coronal sequences, looking at that T1 signal can be very important, as we'll see in some cases that I show later on in the talk. Again, looking for any signs of metastases. If there is, infection is pretty unlikely to show up, asymptomatic, but it's possible. Inflammatory changes or some sort of inflammatory spondyloarthropathy are certainly things that we can see and do see from time to time. Just moving on to some of the other joints. Again, when we're going through and evaluating the joints, we're looking for any signs of early degenerative change. So little osteophytes, joint space narrowing, things like that, subchondral marrow changes. So you can see here in the knee, this person obviously has, pretty advanced degenerative change with narrowing of the joints. They've got some edema here along the tibial eminence on the right knee. They've got osteophytes. They're getting some lateral subluxation of these tibias. So all signs that are showing, pretty advanced changes. If they have fusions, we would be able to see that. And, even though we're not looking at detailed cartilage analysis on these whole body scans, if they have something like an osteochondral defect or a subchondral, insufficiency fracture or something like that, we're going to be able to see this with, sort of moderate edema, this crescentic band of low signal right under the medial femoral condyle here. I'd be very surprised if this person was not symptomatic, or at least they would have a high likelihood of becoming symptomatic very soon, if not already. And then again, the same thing in the ankles, osteochondral defects bilaterally here, so again, we it's a good overview and certainly useful information that a patient would want to know, and you as a provider would want to know about your patient to help them guide therapy to mitigate any symptoms that may or may not be developing. Just another look at the shoulder for this example. So again, we're beginning to see this left humeral head is subluxing posteriorly. We can see some remodeling along that posterior glenoid that's becoming concave with osteophyte formation. So again, we don't always have the most history, which is typical in radiology. We're not always given, the full history. So I don't know, based on looking at this, how much symptoms the patient is or is not having, but I would say there's a good chance that they are, I'd be pretty surprised, especially in this patient with this degree of arthritis, that they wouldn't have some degree of symptoms from it. And again, we can see the biceps tendon here. We're not going to be able to see a subtle, split tear of the biceps tendon, although it looks like it's intact here, but we can see that it's, got abnormal fluid in the tendon sheath, suggesting tenosynovitis. And again, we're going to look at this where you can compare it to the contralateral side, see is the same process going on the other side, which often is, but maybe not to the same degree. And then also, how are the other joints looking out at the same time? And then this patient, this is just an example, there's a large fatty mass here with some somewhat thickened septations in there that are a little bit irregular. You can see it's about 12 centimeters, 5 by 5.8 centimeters in the coronal. This is a coronal T1. Now, on a traditional, standard knee MRI, you would be likely to catch this on here because you pretty much go down to the distal kind of metadiaphysis. If this is a little bit higher, you would miss this, right? And so this may end up just being like an atypical lipoma, but with these degree of septations, this is an example of something that needs to have a dedicated contrast enhanced MRI of this region to further characterize this. And this is potentially either going to need to be biopsied or just resected for the possibility, of excluding a low-grade liposarcoma. And again, limitations. So, we have the large field of view, which is great, and that has its own positives. But with, there's always a trade-off. So the trade-off is really just having lower spatial resolution. So you're not going to get a detailed look at like the cartilage or the labrum or menisci or some of the intrinsic ligamentous structures of the joints. But again, that's not really the purpose or the goal like you would have, say, if you had a patient that had, a knee injury or a shoulder injury where you're looking specifically for those things. So you just have to kind of keep that in mind of, as far as why you're doing the scan and what exactly you're looking for. That being said, we do see secondary signs of some of these pathologies from time to time, but if we don't see that, that doesn't mean that they wouldn't have like a subtle, meniscal tear or something like that. Our full body scan MRI is going to be longer than just a single joint. That being said, 60 minutes to do the whole body is pretty good. Our scans, just like any MRI, is going to require some degree of patient cooperation with motion, because that can definitely degrade image quality. And as Dr. Modi alluded to at the beginning, we have all of our scanners. We have our own specialized whole body protocols that make it very streamlined and efficient to really optimize the image quality that we're getting from our 1.5T scanners, and, looking at all of the joints and all the other structures in the body that we are assessing at the same time. When we compare this to an X-ray, obviously an X-ray is quick, cost effective, but, you're looking at the bones, and that's a great first start, and it definitely has its role. But, you're not going to be looking at all the soft tissues and things like that, like you would with MR. Same thing with CT. You're going to get excellent bone detail, and CT is great for troubleshooting some of the things, some of the incidental bone lesions that we see, from time to time on our exams. Obviously, that comes with radiation. A dedicated MRI, like I've mentioned, that's going to give you the most resolution, the kind of the best detail of that dedicated region, excluding some of the the rest of the body. And then our scans really complement everything that you're going to be getting on some of these other tests, and really helpful for monitoring longitudinally, especially over time. Even if you're not getting the most detailed assessment, if you can see changes or progression of the degenerative change over time, that's going to give a more longitudinal assessment of how fast is this progressing, or is it progressing? Are some of the interventions that the patients are doing on a regular basis, with this information, is that kind of helping to delay or prevent progression of their disease?
Yeah, that's one of the really fun things that we get to see on the longitudinal side, is that patients will come in year one, will describe any signs of degenerative disc or degenerative joint disease that we identify, that we see, and then we'll offer recommendations for intervention. Whether it's posture and ergonomics, whether it's physical therapy or interventions from the orthopedist, and then they'll return to us, and we get to sort of help monitor that progress over time, seeing the patellar tendon looking less inflamed, the quadriceps looking more robust. You can tell that someone has rehabbed their knee. Seeing progression of their cervical stenosis, or seeing progression of their lumbar degenerative disc, that tells us, hey, the weight that you've gained this year has been contributing, your posture at work has been contributing. We just, again, now double down on those interventions. So there really is this kind of really powerful weapon here of watching your patients over time by using a whole body field of view, that we can sort of see multiple joints, multiple areas of concern, as opposed to like really waiting for these things to become a level 10 emergency, and then we try and get the prior authorizations to the insurance companies to get that scanned, right? So that to me is one of the most fun parts of our job, is really having this like early routine surveillance, being able to kind of guide people one way or the other.
Yeah, and and so to that point, for sort of the indications for this, with when it comes to like tumor detection, yes, we see a lot of incidental bone lesions. A lot of times, we can be pretty confident that they're benign or non-aggressive, and they don't need specific follow-up. I showed you that case of that atypical lipoma versus a low-grade liposarcoma. But, when it comes to the musculoskeletal system, assessing like diffuse marrow changes is huge, because, we can see, the whole body and really get a sense. And I'll show you some very interesting cases here in just a little bit of how that can be applied And then I didn't point it out on that case that I walked you through, but that particular patient had a pretty significant gallbladder pathology that was really this kind of really thick rind of nodular soft tissue thickening, that he has no idea about. And that definitely needs further workup to exclude, gallbladder carcinoma. So we're getting, we're doing all the musculoskeletal stuff. And then obviously we're still assessing everything in the body to see, is there something like another tumor or potential malignancy going on that needs to be addressed. For patients that have, a history of inflammatory arthritis, getting a kind of broad overview of all the joints, how they look, if there's any active disease, and being able to assess for that is very helpful. If they have kind of diffuse pain, being able to get kind of a good look at everything at one kind of, go ahead can be very helpful. And then, again, just adding this to the preventative wellness program. I always said if I didn't go into radiology, I would have probably gone into, primary care, outpatient family medicine or something like that. And that's what is one of the really rewarding things for me with what I'm doing now is this is sort of like the primary care of radiology, and being able to implement something like this sort of technology into a kind of a holistic kind of preventative wellness program, I think is very helpful for clinicians. And I think patients, especially ones that I've consulted with, they really appreciate being able to see, what exactly is going on. And I think that can be even more of a driving motivator to get them to take better health and do all the standard lifestyle and, recommendations and diet and exercise and mobility and all that stuff that we all need to be doing. So I want to go ahead and just show some interesting cases. These are all, real cases that we've had in our practice, all are relatively recently. And this is a 50-year-old female that had a car accident, pretty bad car accident about a year and a half before being imaged at her clinic. She had extensive pelvic trauma. She had to have a reconstruction, with RIF of her left iliac bone and acetabulum. And, she didn't put any symptoms or complaints as far as like weakness or pain or anything like that down her, on her left side. But you can see on the side, a couple of these images, you can see the artifact from the hardware. And what I have circled here is some edema involving the kind of like the gluteus medius and minimus and like tensor fascial lata region. You can compare that to the other side, which is normal. Down here more distally in her kind of vastus, quadriceps muscles, you can again see that edema. On this next image, you can compare this to a T1 fat sat. This is showing that, this muscle mass is atrophied. So pretty significant atrophy compared to the contralateral side. Same thing on a standard T1 down here in the lower leg. Kind of hard to appreciate it fully on just a single slice, but there's some kind of feathery, fatty infiltration here along the lateral musculature compared to the right side. On the axial, as you can see, she's got some deformity here of the femoral head, and then there's a lot of artifact, here. This sort of resembles avian additional sequences. That does not look like a real finding. I think that's just artifactual. But this is a patient that's, she's obviously had some sort of injury to her lumbosacral trunk causing these, kind of subacute on chronic denervation related changes diffusely down the left lower leg, causing the muscle edema, the atrophy, and then she's got this, kind of post-traumatic deformity of her femoral head. So, again, she's going to need to see, get a good neurological exam, probably get an EMG, nerve conduction study, to kind of pinpoint exactly where the pathology was. And it's hard to know if the pathology came from the trauma itself or is it related to the surgery. This is another patient with similar findings, another 50-year-old, no reported symptoms, or no reported relevant history. But again, you can see this is a kind of a coronal stir looking through the lower legs, like the calf musculature. So you can see this pretty well demarcated region of edema in the gastrocnemius and part of the soleus. And then on this bottom image, you can see a little bit of asymmetric, feathery, kind of fatty infiltration compared to the contralateral side. And then again, just looking at the, kind of a larger area of the stir, it was a little bit in the hamstrings. That was more subtle. And then down here too. So again, this points to some degree of subacute on chronic sort of denervation related change that needs to be addressed sooner than later, because if she's not symptomatic now, this is likely only going to progress. And by the time she presents with symptoms, it's going to be much more advanced, much more, a much greater degree of muscle atrophy, which right now it's very, very mild. So, trying to get this at this stage to prevent any progression and start the rehab is, going to be huge for this patient. Here was another interesting case that I read recently. This was a pretty simple lipoma. There's, unlike that last case that I showed you that had a lot of, septations inside there, this is all, fatty signal on all sequences, sort of elongated, about 7.5 centimeters in length. And the interesting thing here is that it's displacing the sciatic, it's right here in the sciatic notch, and here's the sciatic nerve being displaced, sort of anteriorly and kind of laterally. I was able to assess the whole, that whole right lower extremity. And, there's no signs of edema or, denervation related changes yet, but this is absolutely something that could potentially cause that over time, whether it changes or whether she gets, just, an injury or some sort of, degenerative change that kind of changes her kind of structure. And, so this is somebody that I would, again, refer to a surgeon, even if they don't want to biopsy this or resect this right away. It's something to keep in mind in case if she does start to have, lower extremity kind of sciatic symptoms. We already know where the pathology is. You don't need to go ordering a lumbar spine MRI right away. So this is, you kind of already have the answer. And, this is something that, has been written about as far as resecting for patients that are symptomatic. So we're able to see it before it becomes symptomatic and then be able to, manage it and address it appropriately.
So Todd, just quick question. So if that patient walked into my clinic, right, and they're complaining of sciatic nerve symptoms, and I do my exam and I decide, okay, we need to get a lumbar MRI, would the field of view of a traditional lumbar MRI capture this lipoma?
No. You on a lumbar MRI, you're kind of getting through the sacrum. Maybe the axial sequences you potentially could see the very top part of the femoral head. You might see if there's like a joint effusion, but you definitely wouldn't get down this low, and this wouldn't be causing any sort of intrinsic pathology of the hip. You wouldn't have a joint effusion like that. So yeah, you would not see this unless if you were doing like a pelvic MRI, for example, or if they were having hip problems and you ordered a hip MRI, you would see this, but certainly not with a lumbar. And this would be more likely to cause sciatic type symptoms than it would, localizing to the hip. So
it's helpful. Yeah. Thank you.
Yep. Here's another, patient, 49-year-old. This person came just for a sort of a preventative wellness scan. And, we see here this sort of abnormal, we call it like a double line sign, where you have this kind of curvilinear band of low signal on T1 in the femoral heads and outlined by this high signal on the stir right here along the superior articular surfaces, compatible with avascular necrosis. We always try to assess, is there any sign of collapse indicating a more advanced stage of avascular necrosis? So here, the femoral head maintains its normal sphericity. So no signs of collapse. It's a little bit larger on the left femoral head than it is the right. There were no effusions on here. So, still a fairly early stage of disease that's unknown. This person, same patient, interestingly also had these bone infarcts, intramedullary bone infarcts, very similar findings of these kind of serpiginous bands of sclerosis on both the distal femurs, kind of right more than left on this one. And you can see the corresponding abnormality on the stir. So this is a patient with bilateral femoral head AVN and distal femoral bone infarcts. This is a 49-year-old African-American male. He has a normal spleen. So you might think about, like thalassemia or sickle cells, something like that, but no history of that. He did have gluteal granulomas bilaterally. He was a pretty muscular build. So, the working possibility is, is he on some sort of anabolic steroids, other sort of, corticosteroid use or other risk factor that might predispose him to getting these kind of bone infarcts. Obviously, he's going to need to have, clinical follow-up and try to identify what the source is. But again, referring to ortho at this stage, as opposed to this going on for another year or two, and potentially, presenting when he's got collapse, which is a much greater, deal, I think is a very good example of how, early intervention, I think can be very beneficial for somebody like this.
That's really helpful, Todd. That's sort of the unintended consequences of people's treatments, right? They're taking supplements, they're taking medications, and then doing something like this periodically, a whole body scan, is going to help us capture any of these unintended consequences. So that's something that I've unfortunately seen in my clinic is patients taking anabolic steroids, developing degenerative hip disease, and it's catastrophic. I mean, this person then goes into her hip replacement surgery and long hospital stays and rehab, all for something that again, perceivably could have been predicted or anticipated.
Sure. Yeah. And then just another case. This is a much more subtle case, of the right femoral head, same findings. Again, it's, you can see that the femoral head's contour is still normal, and it's very hard to see, but I think that they're probably developing it very, very early on the left as well. There was no specific history, explaining to kind of, know why this person is having, developing this right now. But again, being aware of this and then working, with primary care and referring to ortho to get early treatment and preventing, and monitoring this to make sure it doesn't progress is going to be very important to, prevent some of these more catastrophic long-term outcomes. Here's a different case. So this is a 60-year-old, again, just, kind of routine screening. They had an abnormality of their thoracic spine. We can see here that this is sort of an expansile kind of cortical, like trabecular thickening, a little bit of sclerosis here. Notably, the T1 signal is there's still you can still see some fatty signal in there. This is the diffusion weighted image, which really doesn't have it, isn't very helpful on this image or this patient here. But this this is the person had no other signs of malignancy or anything like that. And based on the T1 and kind of like the overall morphology, this is pretty typical of this same disease process that we see here in another patient affecting the shoulder, the humerus. Again, cortical thickening, this kind of coarsened trabecula and sclerosis that we see in the humeral head kind of going down to the diaphysis. And then, some subtle edema here right at the greater tuberosity. And then down here, this is what we call like a blade of grass sign that we can see this kind of triangular kind of band of high signal. And on additional sequencing, you kind of see it going up the diaphysis a little bit more too. So these are all findings that are associated with Paget's disease. And so there, that blade of grass sign can be kind of correlated, a sign of like the sort of the lytic phase, kind of a leading edge of kind of a lytic area that would show up as a lucency on an X-ray or a CT. But again, we're able to characterize this, and this is typically asymptomatic and incidental. But for that spine, for example, if it were to progress, you could get some symptoms if it was causing, or if it was a more severe case, they can have some canal stenosis and that sort of thing. And on a CT, if you were to get a CT on this one, it would show that sort of that picture frame morphology. That's sort of a classic description of a vertebral body. As I spoke about earlier, one of the real big advantages that we see often is, just being able to assess the marrow signal kind of overall. And so this is a 55-year-old, again, no pertinent history provided, but we can see this, sort of subtle increased signal in the distal femurs, proximal tibias, sparing the epiphyses. And then there's some diminished signal of the diaphysis going down to the metaphysis, and same thing in the tibias on both sides. Their spine on this coronal T1, the spine marrow is kind of diffusely diminished, but it's not so diminished that it's darker than the muscle, which is a very important sort of, finding in our observation to keep in mind. So these are all findings that are typical of kind of red marrow reconversion. So this kind of diagram that I pulled offline just shows sort of the normal conversion of marrow from infancy, from 0 to 1 age, where there's lots of red marrow happening down the whole diaphysis. And then over time, that red marrow gets converted into, this fatty replacement. Red marrow reconversion is just the opposite pattern. So it goes from centrally to distally. So you again get more kind of red marrow proximally, and then you're going to start to see that kind of fill in distally. And then, if it's extensive enough, depending on what the risk factor is or the cause of it, is going to, you'll get more or less involving the diaphyses, but you're always going to have sparing of the epiphyses. And, it's going to be that T1 signal is going to be diminished compared to what we consider normal, but it's always going to be brighter than like the muscles or the adjacent disc. So that's something that we always look for as far as raising our level of concern. Is this just marrow reconversion, or is this actually a marrow replacing abnormality that needs further workup. Again, so common triggers, we see that with patients with smoking, chronic anemia, high endurance trainers, obesity, heavy bleeding with menstruation or other, medications can also cause this, similar pattern. And obviously a big red flag is really dark T1. If there's any sort of focal area, if we see any destruction of the cortex, those are all going to be, things that are going to raise our alarm, raise the red flags that this needs to be worked up, and correlating with history and just the basic blood panel obviously can be very helpful. So let's contrast that with this case. So the first thing that shows up besides the marrow is just look at the spleen. I mean, the spleen is down to the iliac crest, so that's definitely abnormal. And if we're looking at the pelvis and the femoral heads, this T1 marrow signal, I can't measure it on here, but we can measure it on the PAC system. But just visually, this is darker than the muscle. It's it's not sparing the epiphyses. It's involving all the way down to that subcortical bone. And with the spleen, highly concerning that this is a more diffuse kind of myeloproliferative disorder. Another example, again, large spleen. You can see I've got the ROIs here measured. So the vertebral body is about 1,075. And that is darker than the adjacent muscle, a little over 1,100. And again, so this one, it is sparing the epiphyses, but that's why it's important to look at everything together. There's a lot of, kind of speckled marrow here in the proximal humeri, a little more speckled kind of islands of marrow changes down here in the distal femurs. But putting it all together, with this dark of T1 signal, the enlarged spleen, again, this is concerning for a myeloproliferative disorder, which was confirmed on follow-up testing. So, extensive marrow signal abnormality, splenomegaly. This person's going to need to get, hemonc evaluation and get, further assessment with whole blood panel and all that to confirm, and potentially, most likely go on to a bone marrow biopsy and the full workup. But again, catching it at a stage pre-symptomatic, before, asymptomatic, way before, way sooner than what it would have got caught had symptoms, waiting for it to be presenting with symptoms. Here's another case, a little bit different marrow case, but again, this is a patient. This is a 64-year-old female that did have some vague back pain, kind of, I think, upper shoulder maybe is what the complaint was that was listed. And as we're going through, here's the sagittal spine that we get to look at the sternum with. And you can see there's a lesion there that's eroding through the back part of that sternal cortex. There's a pathologic fracture of this rib with some edema, and there was an effusion there. This is a diffusion weighted sequence showing, the diffusion is basically a sequence that is very sensitive to look for anything that's highly cellular. So tumors, for example. So this was very bright on diffusion. This corresponds to this sternal lesion. And then in the spine, there was multiple lesions here, this vertebral body in the thoracic level, like in the mid-thorax. And then down here, this left pedicle is dark compared to the other side. So, and then there's another lesion in the skull. So this patient, this was just read, I think maybe 2 weeks ago, a week and a half ago. So we don't have any follow-up on this, but this is all highly concerning for multiple myeloma, versus some other metastatic disease. I didn't see any other primary tumor, so I think myeloma is probably the more likely diagnosis. But again, this patient, other than vague back pain, they don't have any other symptoms. There were some additional foci in the femurs and humeri that could be additional lesions versus islands of red marrow. I wasn't quite sure about. But again, getting this patient promptly to hemonc and getting all the appropriate labs, and then further workup with, PET CT, any sort of dedicated MRI as needed, getting this patient worked up as soon as possible, that's going to be what our goal is. Another case, kind of going away from neoplasm, we mentioned that, we're not getting the same level of detail that we're going to get, say if I was getting a dedicated left shoulder MRI. This is a younger patient, 33-year-old, that did have some left shoulder pain, kind of vague complaints, hasn't had it worked up yet. But this patient has this kind of big dissecting cyst that's originating from the anterior inferior labrum. There's one little kind of band of this kind of linear hyperintensity. It looks like it's most likely a labral tear, but even without that, having a cyst this size this is typically associated with a labral tear. So, and we see paralabral cysts and parameniscal cysts fairly commonly. So even if we don't see the actual tear, it's highly suggestive that there is an occult tear there. And, whether or not they're symptomatic, we may or may not know. But again, just being able to identify that and provide that information to them and let them start therapy sooner than later to hopefully prevent any progression, or if they need to have it, a dedicated exam to have it confirmed, we can point them in the right direction for that.
Yeah, just to pipe in for a second, we catch things like this in our scans, and we obviously correlate it with symptoms that the patient presenting or reporting. And almost the next best utility beyond like recommending treatment, right, is that we're able to fast track that patient towards getting those diagnostic scans through the traditional healthcare system. So now we can put them back into an ICD-10 coded, prior authorization pathway and sort of accelerate or fast track that patient's workup, which sometimes can take months, as we all know, of getting an x-ray and then getting the dedicated scan approved and going through 6 weeks of physical therapy. I've fortunately seen cases where we are able to demonstrate these images on our whole body scan, and that gets them jumping the queue into the diagnostic MRI much faster.
So again, this is just showing this large anterior inferior labral cyst, and the anterior inferior labrum particularly is more likely to be symptomatic than say like a kind of an incidental slap tear that we see very commonly that can be just from chronic kind of degenerative change. And this points to the possibility that this person's having some sort of anterior inferior or some sort of anterior instability. I didn't see a Hill-Sachs lesion on this one. So, but, this sort of thing is exactly what you might see with, somebody that's had a history of an anterior dislocation. And then another sort of incidental mass here, this is in the brachial plexus. So, kind of this vague kind of elliptical kind of ovoid mass that's mildly hyperintense on STIR, hypointense on T1. And then you can see this diffusion restriction, and it kind of gives these tapered margins following right along the brachial plexus. And these are the diffusion weighted imaging, and it looked like on evaluation of this that there wasn't true diffusion restriction, which is a good, sort of a good thing for this patient. But this is most likely a peripheral nerve sheath tumor, like a schwannoma or neurofibroma. And, they've got lots of different imaging features. It's about 3.5 centimeters. If there was true diffusion restriction, that would raise the concern for this being like a malignant peripheral nerve sheath tumor. Either way, this person would go for a dedicated brachial plexus MRI. And just this would probably not be picked up on a routine shoulder MRI. You might barely catch the edge of it, but you certainly wouldn't see all of it, on a routine shoulder. So if they were having any shoulder complaints, you probably wouldn't, you'd be sort of lucky to pick this up. You might see part of it. But this person, I think, would benefit from a dedicated brachial plexus scan and, additional workup. Here's another case. Again, this is another kind of lesion in the sciatic notch. This one is not displacing the sciatic nerve, but you can see this kind of STIR signal hyperintense mass right on T2. So this is not a lipoma. It's got another lesion kind of right next to it, just inferior to it. That was a little bit brighter, a little bit more cystic. And then interestingly, there was another kind of lesion in the thigh that was more subtle that had some STIR hyperintensity. And then this little black dot that's black or dark on the T1 fat sat, bright on the T1 indicates that there's some fat in there along with this. So again, these are going to need further workup, but the fat signal is obviously it's a good thing. This could be a hemangioma here in the thigh, which typically has some fat. There was a little bit of some areas of low signal in these lesions too, which could be some calcification, which would also go with hemangiomas. These could also be some sort of myxoid lesions or peripheral nerve sheath tumors again. But again, asymptomatic. This person's going to need additional workup and monitoring if they're not going to biopsy these, then they at least need to be monitored to see kind of how they're behaving over time.
That was going to be my next question is like, would that be a condition that we could potentially do serial imaging on to monitor before the patient gets kind of, poked and prodded for something that could be a hemangioma, right? So complicated in and of itself.
Right. Yeah. So, that would certainly be the conversation to have between, referring provider and the patient. And, I would refer this one to ortho as well, somebody that's experienced with musculoskeletal tumors to find out, let them decide on how aggressively they want to treat this, whether they, go straight to biopsy or potentially follow it with either our whole body scan or, dedicated imaging of that left hip and thigh. I think would be, appropriate either way. Most likely, if this is unknown, getting a dedicated scan with contrast to fully characterize it is going to be the way to go. And then if it's showing reassuring signs on the dedicated imaging, then following it either again with dedicated imaging or on our scans if they're not going to, resect them. And then here's a case of it's a 43-year-old firefighter looking at the SI joints, which are completely fused. So fairly young patient, solid fusion at the SI joints. There was no edema. There was no signs of active disease, like, soft tissue edema, muscle edema, effusions or anything like that. This person did have a history of rheumatoid arthritis and Crohn's disease. So the kind of working diagnosis is that this could be related to like a kind of a chronic inflammatory bowel disease associated spondyloarthropathy versus RA, was this longer term. So we don't know if this person had, prior imaging, if this was known or not, but this sort of looks like an end stage kind of sacral ileitis sort of picture. So those are all the, interesting cases that we have, for this kind of, I really wanted to show not only just the degenerative stuff that we do that we can monitor and that's so common, but give a good variety or, kind of show a wide variety of what we can do beyond just looking at the joint itself or the, one specific joint, but showing, some of the things that we see, fairly commonly that shows up that really does make a big impact on the patient, to kind of know earlier on than later, before symptoms arise, and really is what the goal of what we're doing, and then hopefully you get an idea of what the strengths that we have as far as being able to look at the whole body at one time, and then the trade-offs that you get between giving up some of the resolution, but really it's coming down to what's your indication for doing, what's your reason for doing it. Did your patient come in for an injury to their that they're trying to get evaluated, in which case you need to get a dedicated scan, versus are they just trying to be proactive and kind of get kind of overall assessment of where they stand right now, and then to guide any sort of physical therapy, exercise programs, any other programs that you might have in mind for your patients.
Yeah, I mean, a few things struck me in this presentation, Todd, and thank you so much for doing this with us, because it really gives me, and I think the other clinicians on this call, such an interesting insight into sort of what can be seen and what can be implemented or implied by this like full deposit of data points. And so things that struck me from the presentation is, number one, the image quality. I mean, we kind of talk about how great the Prenuvo scans are, but to actually see these pictures and the interesting definition and picking up like the difference in these different tissues using our different weightings and like DWI. I mean, this is like really powerful stuff that you wouldn't see on just like a plain film x-ray, right? The next thing that struck me is around this idea of like single session screening of marrow, joints, and spine. And I would add to that like lymph nodes, spleen. We're seeing multi-organ, snapshots of a disease state. And so, identifying things like multiple myeloma and Paget's disease at these early stages, where we can now imply recommendations and we can now start to pursue follow-up testing and treatment at such an earlier stage than what we are unfortunately seeing across the board with sort of mid to late stage diagnoses and interventions. So at that point, the patient's already suffered significantly, is now taking a lot of time and energy and money to kind of figure out what to do. We're able to kind of help get them there much faster and sooner with these very detailed snapshots. So I was really struck by this topic, because I sort of initially envisioned it being mostly focused on degenerative joints and spines, and to be able to see all these other pathologies that are detected on the scan really stood out to me. So thank you again for sharing that sort of breadth of different cases.
Yeah, no, I agree. And I think, to your point, even though it is a whole, large field of view, the protocols are honed to such a degree to optimize what we're getting from that even though we're giving up some degree of, spatial resolution that you would be, if you were doing a single joint, we still get a very good degree of the common degenerative changes and all that. And particularly with the spine, for example, we can still tell you if there's, kind of mild narrowing, severe narrowing, to a pretty high degree, just like you would with a regular, kind of ordering that specific exam, whether it's lumbar spine or C-spine, for example. So, so I agree. I think the image quality is a huge strength, and just being able to use all the different sequences together to, troubleshoot, for when we do see these incidental lesions that come up, frequently. And, oftentimes we're able to put them to rest and, to say this doesn't need any specific follow-up. We can, sort of monitor this routinely. It doesn't look aggressive, doesn't look particularly worrisome. But then, using those things on the other side, when it's time to get dedicated imaging, we've already characterized it, fully. We're obviously not giving contrast and not using the same exact sequences in a protocol for a dedicated exam, but we're able to, give a pretty good idea of exactly where the pathology is, what needs to be ordered next, and then let the, kind of patients go from there and get their workup.
And honestly, expertise like yours helps us put it all together, right? So you're not just studying this from a musculoskeletal position, but you're also looking at this multi-organ and looking at the patient history that's provided, and you're drawing out these kind of inflections and these descriptions that really help us as clinicians put the big picture together. So again, thank you for the talk today. We are running just a little over on time, so I'm going to probably wrap things up. But as always, we welcome questions and feedback. We have the practitioners@prenuvo.com email address set up for anyone watching this call who may want to ask more that we didn't have time to tackle today in the chat. And again, I wanted to thank Dr. Todd Berry for joining us today and for presenting such excellent information. Thank you, everyone who attended today. We really appreciate your interest in what we're doing at Prenuvo, and we welcome any feedback and questions that can come later on. Thanks, everyone on the call. We've got to go. Thank you. Take care.